we'll be discussing about two important topics. One is about weaning from mechanical ventilation and weaning failure, and the other topic is on Eccor. So, more than weaning from mechanical ventilation, weaning failure is very important from a theoretical perspective because there are a lot of questions that have been asked related to this in the recent papers. And Eccor is also being asked frequently in the recent years. So it is important to know about both of them. So we'll go straight into the topic proper. So first I'll be discussing about weaning, and then next I'll be discussing about Eccor. So under weaning from mechanical ventilation, the main topics I'll be discussing is on the introduction, definition, classification of weaning process, the readiness testing, the SBTs or the spontaneous breathing trials, and about extubation. So coming to introduction, weaning from mechanical ventilation is an essential and universal element in the care of a critically ill intubated patient receiving mechanical ventilation. So liberation from mechanical ventilation is a three-step process. So it involves the readiness testing, then weaning, and extubation. So these three are the three important factors that need to be looked into for liberation from mechanical ventilation. So this is just a schematic representation of different stages occurring in a mechanically ventilated patients. So you admit a patient who is admitted with acute respiratory failure, you intubated him and mechanically ventilated him. Then after that, you then suspect whether he is fit for weaning. Then you assess the readiness to wean. Then you perform an SPT. If it's satisfied, you do an extubation. And post extubation, if it does well, it's not a problem. But if it deteriorates, then you'll have to go with reintubation. So this is usually the course that normally is seen. So coming to the definitions, treatment of acute period of care and resolution of the disorder that caused respiratory failure and prompted mechanical ventilation. Suspicion is the point at which clinician suspects the patient may be ready to begin the weaning process. Then assessing the readiness to wean is daily testing of physiological measures of readiness for weaning, like maximum inspiratory pressure or assessment of your rapid and shallow breathing index to determine the probability of weaning success. Then spontaneous breathing trial, that is assessment of the patient's ability to breathe spontaneously, and extubation, that is removal of the endotracheal tube. And reintubation is replacement of the endotracheal tube for patients who are unable to sustain spontaneous ventilation. So these are the basic definitions that need to be known. So coming to the classification of weaning process, we have something called simple weaning. That is, patients who proceed from initiation of weaning to successful extubation on the first attempt without difficulty. Then we have difficult weaning. That is, patients who fail initial weaning and require up to 3 SBTs or as long as 7 days from the first SBT to achieve successful weaning. That is difficult weaning. So you have two criteria. One is 3 SBTs are required or as long as 7 days from the first SBT. Prolonged weaning is patients who fail at least 3 weaning attempts or require more than 7 days of weaning after the first SBT. One thing I want to emphasize here is with relation to weaning, there is no such term as failed weaning. All right. We have either difficult weaning or prolonged weaning. So that is an important take-home message I want you all to look into. So coming to the readiness testing, what it actually is about is that it uses objective clinical criteria and occasional physiological criteria to determine whether the patient is ready to begin weaning from mechanical ventilation. So the main goal of this readiness testing identifies patients who are ready to wean as well as those who are not ready to wean from mechanical ventilation. So how is this going to help? By identifying those who are ready to wean, you are actually avoiding unnecessary complications of ventilation like ventilator-induced lung injury. And by assessing those who are not ready to wean, you are protecting the patient from the risks of premature weaning, like cardiovascular dysfunction, respiratory muscle fatigue, or psychological distress. So that is why readiness testing is important. So considerations for assessing readiness to wean. One is we have a clinical criteria, that is adequate cough, absence of excessive tracheobronchial secretions, and resolution of the disease acute phase for which the patient was intubated. So these three should definitely be there. Then you have objective. One is clinical stability, that is stable cardiovascular status. Heart rate is less than 140 or systolic BP is between 90 to 160 with no or minimal vasopressors. That is, they say noradrenaline up to 5 mics per minute is acceptable with a stable metabolic status. That is, lactates are within the normal limits. Then you have adequate pulmonary function. That is, respiratory rate should be less than or equal to 35 breaths per minute. Maximum inspiratory pressures should be minus 20 to minus 25 centimeters of water. The more negative, the better. And tidal volume of more than 5 ml per kg, vital capacity more than 10 ml per kg, and RSBA of less than 105 breaths per minute per liter, and no significant metabolic acidosis should be there. Then there should be adequate mentation. Patient should not be on any sedatives and should have adequate mentation if they at all they are on sedation. Usually minimal sedative agents like dexmedetomidine or fentanyl and midazolam infusion, if it is being kept, it should be kept at very low rates such that the patient's consciousness is good for assessment with a stable neurological patient. And adequate oxygenation. That is, the saturation should be more than 90% on an FiO2 of 40%, or a PF ratio should be more than 150. And the PEEP should be less than or equal to 8 centimeters of water. So if all these criteria are there, then you can be confident that proceeding for the next step. But one thing to note is that 30% of patients who do not actually satisfy such criteria may be successfully weaned. So many a times in our ICUs, you would have seen there may be patients whom we would have assessed to not be a successful candidate for weaning. Despite that, the primary physician would insist on extubating and seeing. And once you extubate the patient, you will actually see that the patient does well. So such is a scenario. That is, you always don't have to have the objective parameters being satisfied all the time. There are times when the patient will be weaned successfully despite certain criteria not fitting into your readiness to wean. So that is one important thing I would like to emphasize. Then next you have integrated weaning indices. The one which most of us know about is the rapid shallow breathing index, which is the ratio of the respiratory rate to the tidal volume. And the tidal volume is in liters. So if it is less than 105 breaths per minute per liter, it is associated with successful weaning. Then you have something called the crop index. That is, each letter is like an acronym. That is compliance, rate, oxygenation, and pressure. So the compliance that is looked into is the dynamic compliance and the maximum inspiratory pressure. the PF ratio, and that is divided by the respiratory rate. So they say a score of more than 13 is associated with successful weaning. Then you have something called the core index. So core index consists of compliance, oxygenation, respiration, and the effort. The only difference between crop and core is that in place of the maximum inspiratory pressure in core, they use P.1 divided by the maximum inspiratory pressure. So in that, the score more than 8 is been associated with successful weaning. Then you have something called the integrative weaning index. That is a product of your static compliance and your oxygen saturation divided by your respiratory rate divided by the tidal volume. That is your RSBI. But it is supposed to be more accurate than the other predictors, but calculating static compliance is very difficult in a spontaneously breathing patient. So these are the important integrated weaning indices that need to be remembered. The rapid shallow breathing index, crop index, core index, and the integrated weaning index. So once you assess the patient for readiness to wean, you see that the patient satisfies it. Then you go for spontaneous breathing trials. So what are the modalities that are available? One is the TP's trial, where supplemental O2 is supplied through a TPs connected to an endotracheal tube. Then you have CPAP trial. That is, you use if CPAP levels are equal to the previous PEEP levels. This is mainly in pediatric population and it is ideal in COPD patients. Then you have invasive ventilation with low levels of pressure support. That is like pressure support ventilation, whereby you use about pressure supports of 6 to 8 centimeters of water. Then you have automatic tube compensation, which adjusts the flow for the assumed resistance of the endotracheal tube. It's actually a closed loop principle. It's not basically a ventilator mode by itself, but it can be added to the conventional modes. Now, one thing which I want to emphasize is SAMV is not a weaning mode and it should not be used. So based on systematic reviews, there is no difference between TPs and pressure support ventilation in relation to extubation failure or mortality. Either of them can be used. And studies have also demonstrated that patients who fail an SPT do so usually within the first 20 minutes. So the success rate for an initial SPT is similar for a 30 minutes compared to a 120-minute trial. So that is one important thing that you need to keep in mind. So criteria for failure of SBT. We have clinical assessment and subjective indices, whereby you can assess for agitation and anxiety, or there is a dip in the sensorium, there is presence of cyanosis, or evidence of increased respiratory effort, like increased accessory muscle activity, facial signs of distress, or dyspnea. And you have objective measures. The first three parameters are related to your ABG and your respiratory status. The first one is your PaO2, that is if it is less than 50 on an FiO2 of 50% or more, or a saturation of less than 90%. PCO2 is more than 50 mm Hg, or there is an increase in PCO2 more than 8 mm Hg. pH is less than 7.32, or the decrease in pH is more than or equal to 0.07 units. RSBA is more than 105 breaths per minute per liter. Respiratory rate of more than 35 or increased by 50%. Heart rate of more than 140 or increased by 20%. SBP more than 180 or increased by 20%, or an SPP less than 90. My bad, it's not more than 90, it's less than 90, and evidence of new onset cardiac arrhythmias. So if any of these features are present, then the patient is likely to fail spontaneous breathing trials. and the patient has to be put back to the previous mode of ventilation, and weaning should then be attempted only on the next day. So, if at all they succeed your SBT, then you go ahead with extubation assessment. So, we have four components. One is assessment of the optimal timing. Usually, it is done in the daytime when appropriate personnel are available in the event of complications. And also, the daytime is the time when many people are around. So, if any issue occurs, there will be people who help around. Next, you assess the potential difficulty with reintubation, like sedation, obesity, or difficulty during the first intubation. Then, assess for airway protection, that is mentation. Ideally, patients are extubated awake, alert, following commands, and preferably off sedatives or minimal sedation. In neurosurgical group of patients, those with a GCS or 8 or more are likely to undergo successful extubation. Then the fourth important assessment is cough strength and secretion clearance. Cough, informal assessment is assess for cough during deep suctioning. It is an informal method, but it is supposed to be traumatic. And formal assessment is by use of spirometry, whereby you can assess the peak expiratory flow rate. If it is less than 60 liters per minute, then there is a high risk of extubation failure. And you also need to assess the secretions, whether it is thick or thin. And along with the qualitative assessment, you also need to do a quantitative assessment. That is, you assess the secretion volume. So if it is more than 2.5 ml per hour, then it is said that there are increased secretions. And you need to be very, very cautious. So then you assess the risk for post-extubation stridor. So initially you've done an extubation assessment. Then once you do an extubation assessment, you then assess the risk for post-extubation stridor. So for post-extubation stridor, the risk factors are prolonged intubation, more than 6 days, age more than 80 years, traumatic intubation, female sex, excessive tube mobility due to insufficient fixation, insufficient or lack of sedation, aspiration, large endotracheal tube, that is size more than 8 mm in males and more than 7 mm in females. So then if you find that there are risk factors for it, then you assess for the risk of it using a cuff leak test. So qualitative assessment is you deflate the ET cuff, you auscultate over the upper trachea, and you see if there is air movement present or not. If it is there, then there is cuff leak being present. Whereas the ideal one that you have to do is a quantitative assessment. For that, you deflate the ET cuff, you measure the inspired and expired tidal volume of ventilator delivered breaths during volume control ventilation. So the lowest three expired tidal volumes are averaged and subtracted from the averaged inspiratory tidal volume. So normally it should be more than 110 ml or more than 24% of the delivered tidal volume. So this is actually the cutoff that needs to be taken. And other modalities that can be used to assess for possibility of stridor is use of laryngeal ultrasound. But the only problem is it has not been validated yet. So if you find that the cuff leak is not there, that is, it is cuff leak negative, then there is possibility of edema present, then you need to administer glucocorticoids. So the ideal regimen is to give methylprednisolone 20 milligrams every fourth hourly for 4 doses prior to extubation. Or you can also give methylprednisolone 40 milligrams as a single dose 4 hours prior to extubation. Now, the important thing to note is every institution has their own protocol. What I have taken is from the American Thoracic Society, because some institutions give dexamethasone as either 4 milligrams or 8 milligrams fourth hourly or eighth hourly, and then slowly taper it or stop it. So then next coming to the extubation process, the patient should be in the upright position. Then there should be clearance of the ET secretions and then the oral secretions. Then you deflate the ET cuff and remove it. And O2 therapy devices has bridge based on the risk factors for post-extubation respiratory failure. You assess for risk factors if it is there or not. And based on that, you decide whether you want to continue them on NIV or HFMC or maintain them on nasal prongs or OMAP. So the risk factors for extubation failure are failure of two or more consecutive SBTs, chronic heart failure, CO, PaCO2 more than 45 post extubation, presence of weak cough, upper airway stridor being present at extubation, age more than or equal to 65 years, pneumonia as a cause of respiratory failure, and positive fluid balance on the day before extubation. If any of these are present, then you need to be very cautious during your extubation and plan for a bridge to a non-invasive therapy, either a positive pressure ventilation or you need to consider HFNC. So the criteria for extubation failure, one is rate more than 25 breaths per minute for 2 hours, heart rate more than 140 beats per minute or sustained increase or decrease more than 20%, clinical signs of respiratory muscle fatigue or increased work of breathing, saturation less than 90, PO2 less than 80 on an FiO2 of 50% or more, and hypercapnia, that is a PaCO2 more than 45 or more than 20% from the pre-extubation pH. And pH if it is less than 7.33. With the background of a respiratory acidosis, you need to be very, very careful because they are high likely going to go into an extubation failure. So we have discussed about weaning from mechanical ventilation. So next, if at all the patient has had a difficult weaning or a prolonged weaning, you need to assess for it. It is weaning failure. So I've divided it into 3 parts. Again, I'm emphasizing weaning failure is the very commonly asked long question in theory. So please please try to concentrate on the upcoming slides. So difficult weaning contributes to about 26 to 39% of weaning patients. That is about almost one third of patients. And it consumes one third of your ICU resources. It is associated with increased patient discomfort, increased mortality, that is almost 25%, and increased length of ICU stay. So, is there any predictor of prolonged mechanical ventilation? Yes. There is something called the I-track criteria. So, each letter has a value. That is, I stands for intubation and ICU, or hospitalized in ICU more than 24 hours. T is tachycardia, that is heart rate more than 110. Then AKA, that is blood urea nitrogen more than 25 milligrams per deciliter. Presence of acidemia, that is pH less than 7.25. Creatinine more than 2 milligrams per deciliter or 50% increase from baseline. And bicarb less than 30 milliequivalents per liter. So, I tract intubation, tachycardia, renal dysfunction, acidemia, creatinine, and bicarbonate. So, if 4 or more of the parameters are positive, they are more likely to require mechanical ventilation more than 7 days. But the problem with this is the sensitivity is relatively poor and the specificity is only modest. Only gives you a specificity of 82%. But from an exam perspective, if at all they ask you if at all the presence of validated tools for prolonged mechanical ventilation, then you must know that there is something called the eye track criteria. So when you come to weaning failure, there has to be a certain approach that you need to go by. Okay. So you can split it into various systems: respiratory, cardiac, neurological, psychiatric, endocrine, metabolic, and nutrition related. So if you go in this stepwise manner, both for theory and your practicals, it will be very beneficial. So coming to respiratory system related weaning, the usual etiology is either because of increased airway resistance, which can be attributed to the large airways or the small airways and manifest as bronchospasm. Or it can be because of reduced compliance, which can include the chest wall or the lung. And the common causes are usually fluid overload, pneumothorax, pleural effusion, consolidation, and atelectasis. So, when do you suspect a respiratory cause? In general, in patients with COPD, asthma, and ARDS, always, if at all you have a difficulty with weaning, the most common etiology to be attributed is supposed to be respiratory. So other scenarios where you suspect respiratory causes in patients with a reduced compliance, and if at all there is development of intrinsic PEEP, that is expiratory flow limitation, high breathing frequency, loss of elastic recoil of the lung, or if there is patient ventilator asynchrony, that is ineffective triggering. So based on certain studies, they found that intrinsic PEEP was higher in COPD patients with weaning failure compared to those who are weaned successfully. And the duration of mechanical ventilation was significantly longer in patients with ineffective triggering. That is, more than 10% of all breaths compared with those having lower incidence of ineffective triggering. All right. So these are the two important factors that need to be looked into and have been associated with delayed weaning: intrinsic PEEP and ineffective triggering. So how do you go about assessing these issues? So for increased airway resistance, the best thing is first you auscultate the chest for these. Then you can go ahead with flow time loops or pressure time scalars, whereby you can see there is a marked variation between the peak pressure and the plateau pressures. That is, or there is an increase in your trans airway pressure, and assessment of intrinsic PEEP, that is use of expiratory pause. So using all these, you can come to a conclusion whether there is an increase in airway resistance. Whereas for reduced compliance, you can go again, you can auscultate and see for the presence of Krebs. Then you can go with radiological assessment like ultrasound, chest X-ray, or CT for pleural fluid atelectasis, ascites, consolidation, or volume overload. So these are few images. This is the pressure flow time scalar where you can see that there is incomplete expiration. So before the expiratory phase gets over, the next breath occurs. So because of that, there is breath stacking which occurs subsequently. And here you can see that the set PEEP, and here you can see that once an expiratory pause is placed, there is an increase in the auto PEEP, which is more evidently visualized. And here you can see there is an increase in the trans airway pressure. That is, the top one is your peak pressure and the one over here is your plateau pressure. So this difference is your trans airway pressure. And usually they say if it is more than 10 centimeters of water difference, then it's supposed to be considered significant. So coming to the management for increased airway resistance, you go with bronchodilators and steroids. If intrinsic PEEP is present, then you will have to adjust the ventilator settings. That is, if at all the patient's on pressure support ventilation, then you modify the inspiratory cycling from 5 to 40%. You reduce the minute ventilation, increase the IE ratio if the patient is on control mode, and increase the inspiratory flow rates so that there is adequate time for expiration. And in advanced management, you can go ahead with the diagnostic bronchoscopy during SPT, so that if at all there is any mucus plug which is causing air increase in airway resistance, then that can be sorted out. With regard to reduced compliance, you will have to mainly work on optimizing compliance, that is use of PEEP, then reducing the edema of the lung and chest wall by using use of diuretics if it is feasible, and resolving atelectasis by physiotherapy. Whereas if there is significant effusion, that is effusion or ascites, in advanced management, you will have to go ahead with thoracentesis or paracentesis. Then coming to the cardiac etiologies, the transition from mechanical ventilation to spontaneous breathing imposes an additional load on the cardiovascular system because of the intrathoracic pressure changes, which affect the ventricular preload and afterload and increased O2 consumption by the respiratory muscles. So the easiest way to explain this is positive pressure ventilation with application of PEEP has a beneficial effect on the heart because it reduces the transmural pressure and it reduces the afterload. Once you get the patient into spontaneous ventilation, that is into weaning mode, all this positive pressure and PEEP is lost. So because of that, of these pressure changes, there is change in the transmural pressure, which again reflects as an increase in your afterload. And because of that, that will cause an increased stress on the heart. And that may predispose to weaning-induced cardiovascular dysfunction. So it can occur in up to 59% of the patients, that is almost in 2/3 of the patients. And it can either manifest as a myocardial ischemia or present as acute heart failure. So when do you suspect cardiac causes? Usually in patients with pre-existing cardiac diseases or in COPD patients, you always need to suspect a cardiac etiology. In COPD patients, you also need to look for respiratory causes also. So if at all you get a patient with COPD on mechanical ventilation and you have breathing difficulties, you need to go on a very holistic approach because any of the systems may be involved or there can be combination of system involvement also. So mechanism of weaning-induced pulmonary edema is the patient may have a latent ischemia which may not be detected. But once you put the patient on SPT, like I said, when you because of the pressure changes and changes in the transmural pressure and increase in afterload, that can impose a stress on the heart and cause a manifest ischemia. Now, because of this manifest ischemia, there is a supply-demand mismatch that occurs within the heart, and that causes a decrease in LV compliance with an increase in LV afterload. So that leads to pulmonary edema, which causes a decrease in lung compliance, leading to increased work of breathing, which ultimately leads to weaning failure. So for assessment of a cardiac etiology, it is always important to do a 20 ECG before and at the end of SPT and an echocardiography and before at the end of SPT. And to always assess for history, predisposing risk factors, and exclude other causes prior to cardiac evaluation. So once you do this, you do a lung ultrasound and also do a BNP or pro-BNP. So there was one study where they demonstrated that SPT induced increases in BNP by more than 12%, suggest a diagnosis of weaning-induced pulmonary edema contributing to weaning failure with a sensitivity of 76% and specificity of 78%. Now, you may ask, why BNP, why not pro-BNP? You can use it, but the problem is the studies that have been done have been in relation to BNP. So with that, they have come with a cutoff of 12%. But the problem is with pro-BNP, they have not come with any specific numbers. So that is why I have mentioned specifically about BNP. But if you feel that there is a marked increase in pro-BNP from the baseline, then that itself can be one of the markers suggestive of weaning-induced pulmonary edema. So coming to the management, the initial management would be preload reduction, that is use of diuretics and PEEP, afterload reduction, use of inotropes of vasodilators. And if ischemia is present, you will have to consider beta blockers and optimize the hemoglobin and optimization of your cardiac medications. That is, if they are on heart failure medications, then the doses need to be adjusted. Despite all these measures, if there is not much of improvement, then you will have to go with advanced interventions like use of levosimendan, pulmonary artery catheter insertion, or cardiac interventions like coronary angiogram if it is feasible. Then you assess for neuromuscular, that is diaphragm or respiratory muscle function. So initiating our spontaneous weaning trial puts an acute load on the inspiratory muscles. So the elevated load is imposed on a weakened respiratory muscle pump. When considering the inspiratory muscles as a cause for weaning failure, it should be kept in mind that dysfunction of the ventilatory pump may result from a lesion anywhere from the afferent chemoreceptors of the respiratory centers till the contractile proteins in the intercostal muscles or diaphragm. So, right from the brain till the muscle, there can be any lesion which can lead to neuromuscular dysfunction and manifest as weaning failure. So, impaired respiratory drive is usually an uncommon cause of weaning failure. In fact, in most patients, weaning failure patients, the respiratory drive is increased actually. So, occasionally, clinically relevant diaphragm dysfunction results from damage to the phrenic nerves, and the most common disorder affecting the phrenic nerves is critical illness polyneuropathy, that is CAPN. So, when do you suspect neuromuscular etiology as a cause of weaning failure? Usually on patients on long-term mechanical ventilation. So, initial assessment is by use of serial neurological examination, that is to evaluate for other causes other than ICU acquired weakness. That is, use of the MRC score can be done. Then you can go with assessment of your PA max. Then the P.1 can be done. Then ultrasound assessment can be done. That is by use of your diaphragm excursion or your diaphragm thickness fraction. And advanced assessment can be done by use of diaphragm fluoroscopy, nerve conduction studies, or muscle biopsy. So maximum inspiratory pressure is a global assessment of the inspiratory muscle function that can be obtained by measuring the maximum inspiratory pressure. So I'm just emphasizing it again. It is a global assessment of inspiratory muscle function. So the lower limits for maximum inspiratory pressure in healthy subjects younger than 65 years old is minus 75 centimeters of water in men and minus 50 centimeters of water in women. Values that are more negative virtually exclude significant inspiratory muscle weakness. That is, it has a good negative predictive value. But values that are less negative do not prove muscle weakness, as this method depends on cooperation and it also depends on the lung volume. So there is an important terminology called P.1. So it is the most frequently used test to evaluate respiratory drive. All right. P.1 is synonymous with the respiratory drive in mechanically ventilated or spontaneously breathing patients. That is airway occlusion pressure at 100 milliseconds, P.1. The inspiratory limb of the ventilator is occluded and a drop in airway pressure is continuously monitored in normal subjects. And the normal values is about 0.5 to 1.5 centimeters of water. All right. So it is used to assess respiratory drive and it is the airway occlusion pressure at 100 milliseconds. So and the normal value is around 0.5 to 1.5 centimeters of water. So it should be noted that P.1 depends not only on the respiratory drive, but also on the inspiratory muscle capacity. So A reduced P.1 is not a very specific sign of impaired drive, but in patients with a normal or high P.1, impaired central drive can be confidently ruled out. All right. So P.1 indicates both respiratory drive and inspiratory muscle capacity. So if it is low, it does not specifically mean that the drive is poor. It can also imply that the inspiratory muscle capacity is also low. But if at all it is normal or high, it rules out as an impaired central drive. Then you have assessment using ultrasound, whereby you can use the diaphragm thickness fraction. If it is more than 30%, and it is an indicator of successful weaning, and excursion, if it is more than 1.1 centimeters, then it is also an indicator of successful weaning. An important point to note is the definitive diagnosis of respiratory muscle fatigue after a trial of spontaneous breathing is not feasible in routine critical care. The development of hypercapnia during a weaning trial is not a very specific finding, as hypercapnia may result from causes other than muscle fatigue, such as central hyperventilation and rapid shallow breathing. But the absence of hypercapnia in a weaning failure patient virtually excludes inspiratory muscle fatigue. So, with regard to management of neuromuscular etiology as a component of weaning failure, the main management is early mobilization, tight glycemic control, antioxidants, and more time on support mode of ventilation, which has shown to be associated with reversal of ventilatory-induced diaphragmatic dysfunction. The next component of assessment for weaning failure is psychiatric. Delirium or oversedation may limit ventilation due to decreased cooperation with SBTs. So patients with delirium are twice as likely to be difficult to wean candidates. So that is very important to note. So when do you suspect psychiatric etiology for weaning failure? In patients with a previous history of dementia, delirium, or substance abuse, long-term exposure to benzodiazepines. So in these subset of patients, you need to suspect a psychiatric etiology. So initial assessment, you can go with the CAM-ICU score, and in advanced assessment, you can go with psychiatric evaluation for depression or anxiety. So this is the CAM-ICU score. I'll just mention the 4 areas that you need to look into. One is the acute change or fluctuating course of mental illness. Then second is inattention. Third is altered level of consciousness. And fourth is disorganized thinking. So if at all you assess for all of this and you find that there is possibility of delirium present, then you will have to start on appropriate medications or appropriate interventions. So I hope most of you know about how to go about the CAM-ICU score. For those who have not been exposed to this score previously, I'll just give a small overview. For acute change or fluctuating course of mental illness, you assess if there is a acute change from the mental status baseline, or you assess if there is a change in the mental status over the last 24 hours. So if it is not there, then CAM-ICU is negative. There is no delirium. Whereas if it is positive, you go for inattention. So you ask the patient to squeeze your hand every time you tell a specific letter. Then you repeat a set of letters and with the letter that you had in mind and which you had conveyed to the patient. Like example, the letter A. So if they make more than 2 errors, then you go to the next test. Whereas if it is only 0 to 2, then CAM-ICU again is negative. For the altered level of consciousness, you assess the RAS score. So if RAS is anything other than 0, that means three criteria have been met and the patient is CAM-ICU positive. And that indicates there is presence of delirium. Whereas if the third, that is altered level of consciousness is not abnormal, RAS is 0, then you go for disorganized thinking. So you ask various questions, abstract questions, and you assess the response. So if it is only 0 to 1 error, it is CAM-ICU negative, there is no delirium. But if there is more than one error, then CAM-ICU is positive because the first two criteria are satisfied and then the fourth criteria is also satisfied. So that will lead to CAM-ICU being positive and delirium being present. So this is the way to go about with the CAM-ICU assessment. So there will be a separate class on delirium in ICU. During that time, again, this CAM ICU score and the intensive care delirium checklist score is also there. That will also be discussed more in detail. So coming to the management, we have non-pharmacological measures whereby you can improve the orientation by providing visual and hearing aids, reorient the patient, and provide family engagement, and provide environmental measures like sleep hygiene, that is switching off the lights at night, control excessive noise, early mobilization and exercise, and music, and clinical to maintain the systolic BP more than 90, treat metabolic derangements like hypoglycemia, electrolyte imbalances, and maintain the oxygen saturation more than 90%. And pharmacological measures are advised if at all the non-pharmacological measures are not effective or the patient has severe delirium. In those cases, dexmedetomidine is the ideal drug of choice. Atypical antipsychotics like quetiapine, olanzapine, and risperidone can be used, or typical antipsychotics like haloperidol also can be used. Then you have nutritional etiologies, whereby you can have two subsets, underfeeding or overfeeding. In underfeeding, there can be increased protein catabolism that itself can lead to respiratory muscle weakness. And in overfeeding, there can be increased carbon dioxide production and that can lead to increased ventilatory demand, leading to weaning failure. So you suspect nutritional etiologies in patients with pre-existing malnutrition, high Apache 2 score, that is high severity of illness, and it should be only considered after all the other common causes are ruled out. That is cardiac, respiratory, neuromuscular, psychiatric. If after these all are ruled out, then we can look into nutritional. And assessment for that is by indirect calorimetry, and management is provision of adequate energy intake. If they are underfed, you progressively increase the feeds. You also keep monitor for refeeding syndrome. And if they are overfed, then you have to come down on the calorie intake. Then you have metabolic assessment or metabolic etiology, whereby you have hormonal etiologies and electrolyte imbalances. So hypophosphatemia, hypomagnesemia, hypokalemia, or metabolic acidosis. All these can contribute to muscle weakness. Or if the patient is on corticosteroids, that itself can lead to myopathies leading to muscle weakness, or it can lead to hyperglycemia, and hyperglycemia can cause skeletal muscle weakness, leading to difficult weaning. Hypoadrenalism and hypothyroidism can lead to difficult weaning, but there is no direct correlation between these two and difficult weaning. It can cause. There are not any robust articles that have shown a good correlation between these two. So, when do you suspect metabolic parameters? Only after cardiac, respiratory, neuromuscular, and psychiatric causes are ruled out. And if you find that there is severe electrolyte imbalances, then you suspect a metabolic cause. So initial assessment, you do an electrolytes and assess an ABG because, as I said, metabolic acidosis can lead to skeletal muscle weakness. And advanced assessment, you can check the plasma cortisol levels and the thyroid function test. So management is by IV electrolyte supplementation plus or minus hormonal replacement. That is either steroids or thyroxine. So, if at all the patient has a weaning difficulty, you have assessed the cause, you have tried to address it, but still the patient keeps failing. There is a point in which you can keep the endotracheal tube. So that will have a big impact on your rehabilitation also. So that is one area where the role of tracheostomy comes into play. So the advantages of tracheostomy is easier airway management, reduction in sedation use, earlier weaning from respiratory support, improved respiratory mechanics, early transition to oral feeding. But there are complications associated like misplacement, and especially if it is within the first 2 weeks, it can be very catastrophic. There can be bleeding, obstruction, infection, and in late scenarios, there can be tracheal stenosis. So the optimal timing is still not clear. And the techniques that can be used are either percutaneous or surgical. So either of these can be used. So just for a small revision, when you go with weaning failure, you assess first for the respiratory. The respiratory you assess for airway resistance and you assess for lung, reduced compliance. So for airway resistance, you assess for bronchospasm, and for compliance, you assess for presence of consolidation or volume overload or effusions or presence of ascites, and you manage accordingly. Then you assess for cardiac. So in cardiac, you see patients who are susceptible, like previous heart disease or COPD. Then you assess the background of how the SBT is going. You do a pre-SBT ECG and a post-SBT ECG. Then you also then assess the echocardiography and subsequently do a pro-BNP, do a BNP. Why only BNP rather than pro-BNP? Studies that have been done have been exclusively only on BNP, not on pro-BNP. So the management for that is like for acute heart failure, where you need to reduce the preload and the afterload, and advanced measures like inotropic support with levosimendan and coronary angio, if necessary, should be considered. Then neuromuscular assessment. Then after neuromuscular assessment, you need to assess for psychiatric evaluation. Then for after psychiatric evaluation, if it is insignificant, you go with nutritional assessment. You see if there is underfeeding or overfeeding. Then after that, you assess for metabolic parameters, whereby you assess for electrolyte imbalances, you assess for metabolic acidosis, you assess for hyperglycemia if the patient is on corticosteroids. And along with that, you also assess for any hormonal issues, that is like hypothyroidism or hypocortisolism. And if they are there, it needs to be corrected. And ultimately, if at all there is a difficult meaning, the ideal choice for further airway management would be to go with tracheostomy. So completed the first discussion. The next is on Eccor. So Eccor, this is a relatively shorter presentation, and it is important because, like I said at the beginning of my talk, there have been a lot of questions based on Eccor that have been asked in the FAT exams and recently also asked in your theory exams. So it is important to know about it. So the areas I will be covering it is the introduction, the physiology, the clinical applications, contraindications, technical aspects, supportive care, complications, weaning, and related trials. So coming to the introduction, extracorporeal carbon dioxide removal, that is Eccor, is an advanced form of life support that is mostly used in patients with severe hypercapnic respiratory failure without hypoxemia. Eccor is like ECMO, but uses lower blood flow, usually less than 2 liters per minute. So this technique has little or no impact on blood oxygenation, unlike ECMO, where 3 to 7 liters per minute flows enable both adequate oxygenation and carbon dioxide removal. So coming to the physiology, the role of Eccor as far as hypercapnic respiratory failure is concerned is by removal of carbon dioxide through the extracorporeal circuit, it allows a decrease in respiratory rate, allows an increase in your expiratory time, and allows a decrease in the respiratory drive. So because of these, there is a decrease in your dynamic hyperinflammation and a decrease in your muscle fatigue. So which ultimately helps in increasing the carbon dioxide elimination, and also because the muscle fatigue is reduced, there is a decrease in your carbon dioxide production. So that actually helps in correction of your respiratory acidosis. And because the dynamic hyperinflammation is coming down, it helps to improve the precapillary, reduces the precapillary pulmonary hypertension and improves the right heart function. And in patients with ARDS, it helps to reduce the tidal volume to less than 6 ml per kg, thereby reducing the plateau pressures, the driving pressures, and the mechanical power, while maintaining the pH and the PaCO2. So this is the main benefit of Eccor. So coming to the clinical applications, its main benefit is in patients with status asthmaticus, where it is most commonly used. So patients with an acceptable oxygenation but severe uncompensated respiratory acidosis, that is pH less than 7.2, or evidence of excessive dynamic hyperinflation despite optimization of medical therapy. If oxygenation is also compromised, then VV ECMO is the preferred modality. Then other areas where it can be used is in end-stage lung disease as a bridge to lung transplantation. That is in patients with acute or chronic hypercapnic failure, in acute exacerbation of COPD to facilitate weaning or avoid mechanical ventilation, and in moderate to severe ARDS. And contraindications are, we have absolute, that is severe irreversible non-cardiac origin failure or condition limiting survival, that is severe anoxic brain injury. No transition to a well-defined endpoint, that is recovery or transplantation, severe aortic insufficiency or aortic dissection. All these are absolute contraindications. And relative contraindications are severe coagulopathy or contraindication to anticoagulation, severe immunocompromised state, prolonged duration of mechanical ventilation more than 7 days, and lack of resources to support ECMO-associated care, and advanced stage, usually age more than 80 years. So coming to the technical aspects, the first thing I need to discuss is about the configurations. So there are 3 configurations that are there. The first one is the two-side veno-venous extracorporeal membrane oxygenation. So here you can see there is a drainage cannula through the femoral vein. It passes through the circuitry where there is a blender and oxygenator. And once the carbon dioxide is removed, it then returns through the internal jugular vein. Then you have a single site veno-venous extracorporeal membrane oxygenation. That is, here you have a double lumen catheter. So through one of the lumens, there is a drainage port, and that passes through the pump, through the blender, through the oxygenator, and through the return port, it comes back into the heart. So the blood that is pump that is drained from the central vein is usually situated either in the superior or the inferior vena cava, and the blood that drains, the blood that returns back to the heart drains into the right atrium. Then you have something called the pumpless arteriovenous bypass, that is the AV Eccor. So this is usually used only in a certain subset of cases. The main component of the configuration of this setup is blood flows from the femoral artery to the contralateral femoral vein, creating a pumpless arteriovenous bypass equipped with the artificial gas exchanger across the AV shunt. So it allows the sweep gas to remove the carbon dioxide, that is through the membrane lung. The important thing is that the arteriovenous pressure gradient needs to be more than 60 mm of Hg, and the cardiac index needs to be more than 3 liters per minute per meter square. Only if these two are satisfied, you can actually consider for an AV Eccor configuration. This is usually unsuitable for patients who are hemodynamically unstable. So just a small revision, we have, like in ECMO, we have two-side cannulation. That is, one femoral and the other return is through the IJV. Or you have a double lumen catheter through which one port will serve as the drainage and other one is through the return. The drainage is from the SVC or the IVC, and the return is through into the right atrium. And for the pump plus AV bypass, the drainage and the return are through the femorals. That is the femoral artery and the femoral vein. The only prerequisite is the arteriovenous pressure gradient should be more than 60 and the cardiac index should be more than 3. So it is unsuitable in hemodynamically unstable patients. So coming to the technical aspects, for catheter insertion, where oxygenation in ECMO is largely dependent on the circuit blood flow rate, CO2 removal is primarily determined by the sweep gas flow due to the efficiency with which carbon dioxide transfer occurs across the membrane. Therefore, Eccor can be achieved with lower blood flow rates and correspondingly smaller cannulae, that is around 15 to 19 French, than what is actually required for oxygenation during ECMO. However, if there is an anticipated need for extracorporeal oxygenation, we place larger cannula to support ECMO should it be needed at some point during the patient's illness. So coming to the technical aspects, the initial settings and titration. So following cannulation, the patient is immediately connected to the Eccor circuit, typically the pump, the membrane lung, and a monitor, with the sweep gas, which is a blend of oxygen and air, the fractions of which are determined by the provider and set through a blender, and is connected to the membrane lung. There is actually no universally agreed upon initial settings. It is more of a trial and error. As an estimate, the following are achieved incrementally over the first few minutes after initiation. So pump speed to achieve extracorporeal blood flow appropriate to the pump. It can be as low as 0.4 to as high as 3 liters per minute, or it can be greater based on the cannula size that is used. So the smaller the cannula, the lesser the flow. So that goes by the Poisson equation. So Poisson equation, as I discussed in the previous class, flow is proportional to the pressure and the fourth power of radius divided by and is inversely proportional to the viscosity and length of the tube. The sweep gas flow typically ranges from 1 to 10 liters per minute, and the fraction of delivered oxygen can be adjusted between 0.21 to 1. So for those with marked uncompensated respiratory acidosis, example of PaCO2 of more than 60 millimeters of mercury with corresponding acidemia, the sweep gas flow should be increased very gradually, because high variations in your sweep gas flow can affect the PaCO2 levels in the brain. And if at all there is a marked elimination of PCO2 from the body, that can reflect in the brain because hypocapnia in the brain can cause cerebral vasoconstriction and that can impair the circulation. And on the other hand, if at all the PCO2 trend is not adequately managed properly, then that itself can lead to intracerebral hemorrhage. So, market shifts in your PCO2 level should not be there. It should be always gradually reduced or increased. The next aspect is in relation to supportive care. With regards to invasive mechanical ventilation, you need to reduce the minute ventilation, that is the tidal volume and respiratory rate, to decrease the stress and strain on the lung parenchyma. Prolong the expiratory time, especially in cases of acute exacerbation of asthma or COPD. Discontinuation of neuromuscular agents and minimization of sedatives to facilitate early extubation. Circuit management and monitoring. You need to assess the complete blood counts on a daily basis because the patient is on extracorporeal circuitry. Thrombocytopenia can occur, anemia also can occur. So you need to assess for hemolysis. You need to assess the LDH, total and indirect bilirubin. We need to do arterial blood gases on a regular basis. The coagulation studies as per initial institutional protocols. Usually on day one, ACT is checked. Usually from day 2 onwards, APTT is checked in most centers. Then chest radiography needs to be done to assess the tube positions. And ECMO circuit-related pre- and post-membrane pressures and blood gases need to be assessed. And ECMO-related cannulation site should be assessed for bleeding and infection. So almost like how we had discussed for a patient on VV ECMO, it is almost a similar management for patients on Eccor. So coming to the complications, you have patient-related complications like anticoagulation-related bleeding, hemolysis, heparin-induced thrombocytopenia, and recirculation. Then you have catheter-related complications like catheter side bleeding, catheter malposition, displacement or catheter kinking, catheter infections, vascular occlusions, thrombosis, hematoma, or aneurysm. And device-related complications like pump failure, oxygenator failure, clot formation, air embolism, and heat exchange malfunction. So weaning, it is similar to that of VV ECMO. Once the underlying disease process has sufficiently improved and it is assessed that the patient is adequately supported with conventional mechanical ventilation, we start to wean from Eccor. So once the sweep gas flow has successfully been decreased to a low level, that is about 1 liter per minute, typically in conjunction with the liberalized ventilator settings, we turn off the sweep gas flow, that is off sweep challenge for about 30 minutes and then perform a ABG. So oxygenation with an FiO2 of 0.6 or less and PEEP of 10 centimeters of water and less and maintaining a PO2 of 60 mmHg or more. And you have a ventilatory parameters of a pH more than 7.35 with a tidal volume of about less than equal to or less than 6 ml per kg with plateau of less than 30 and a rate less than 28. If these criteria are satisfied, then you can proceed for decannulation. Another important thing is there should not be any excessive work of breathing. So these numbers are very, very important. For oxygenation, FiO2 of 0.6 or less, PEEP of 10 or less, PO2 of 60. So 0.6, 10, and 60. And for ventilation, the pH of 7.35 or more with a tidal volume of 6 ml per kg or less, plateau of less than 30, rate of less than 28. So these criteria are there, then you can proceed for decannulation. And anticoagulation should be discontinued for 1 to 2 hours prior to decannulation. So that is also very, very important. So important trials related to Eccor. One is the Supernova trial that came in 2019. So the clinical question was, can Eccor safely facilitate ultra-low tidal volume ventilation in patients with moderate ARDS? So the conclusion was it can facilitate ultra-low tidal volume ventilation, but it had no relation. They had not done much studies or workup in relation to mortality. Then came the REST trial that came up in 2021. So the clinical question was, in mechanically ventilated patients with acute hypoxic respiratory failure, does lowering tidal volume using Eccor compared with conventional low tidal volume ventilation improve day 90 all cause mortality? So the conclusion was, in patients requiring mechanical ventilation for acute hypoxic respiratory failure, lower tidal volume ventilation facilitated by Eccor compared with standard care did not result in a reduction in mortality at 90 days. All right. So the one supernova was a positive trial and the rest trial was a negative trial. Thank you. Dr. Niharika will be coming for the next class. Madam, you join, ma'am?
You finished, no, Srihari?
Yeah, I finished, ma'am.
Okay, thank you.
Thank you.
Good evening, all. So we will continue with the endocrine topic. So yesterday we discussed about SIADH. So today we will be dealing with the thyroid storm. So the outline of the topic would be introduction, the precipitating factors, what is the pathophysiology, the clinical features, diagnosis, treatment, and the complications. So, the thyroid storm is a rare but one of the serious conditions which carries a high risk of morbidity and mortality. So, before going into the proper topic of thyroid storm, first we will know the different definitions and what is the difference between the each term, which is very important. So, what is hyperthyroidism? So, hyperthyroidism is excessive synthesis and secretion of the thyroid hormone from the thyroid gland. That's the secretion of the thyroid hormones, excessive secretion. Now, what is thyrotoxicosis? It is the clinical manifestation of symptoms due to the excess production of these T3 or T4 in the peripheral tissues, regardless of the source. Okay, that is thyrotoxicosis. Now, what is thyroid storm? It is a life-threatening condition which is characterized by exaggerated signs and symptoms of the thyrotoxicosis. Plus, important thing is there is evidence of multi-organ decompensation. Okay, exaggerated signs and symptoms of thyrotoxicosis along with involvement of multi-organ, it is nothing but the thyroid storm. So you should know all these three definitions and what is the difference between each of it. Okay. So coming to the precipitating factors for thyroid storm. So the most important thing is interruption in drug therapy for hyperthyroidism or medication non-adherence. That is the most common precipitating factors. The others could be underlying Graves' disease, or if there is any new onset of infection, or if the patient has recently underwent thyroid or non-thyroid surgery, acute MI, or a pregnant lady who has preeclampsia or any hydatiform mole, patients who have trauma or burns, exposure to exogenous iodine, like any contrast or a radioactive therapy, or certain medications which may lead to thyroid storm, like amiodarone, lithium, sunitinib, interferon alpha, and in around 24 to 43% of cases, there is no identifiable trigger. Now, this is just um, a table which gives the common causes as well as some rare causes. So if you have time to go to through it, you can go. I've just mentioned it. So as I told, common causes could be non-adherence to the thyroid medications, drugs like amiodarone, any emotional stress, non-thyroid surgery, preeclampsia, labor, psychosis, trauma, and rare causes could be the others. Now, the causes of death in thyroid storm, the most common is multi-organ failure. Okay, the others could be congestive cardiac failure, any arrhythmias, respiratory failure, DIC, GI perforation, hypoxic brain injury, and sepsis. Now, coming to the pathophysiology. Before going to the actual pathophysiology of thyroid storm, we will just know what is the normal thyroid physiology, thyroid hormone synthesis, and the physiology. So, as we all know, the major stimulant for the thyroid hormone secretion is basically if there is a low metabolic rate or the levels of the thyroid hormones in the blood are low. Okay. So whether the metabolic rate, you're going to say about the metabolic rate and or T3, T4 concentration in the blood. If it is low, then the hypothalamus gets stimulated to release the thyroid releasing hormone. This thyroid releasing hormone will act on the pituitary to secrete the thyroid stimulating hormone. Okay. When this thyroid stimulating hormone is released, it acts on the thyroid follicular cells. Okay. So thyroid follicular cells, when it acts on it, it causes the release of T3 and T4, which acts on the peripheral tissues. Okay. Suppose if their concentration is increased, then there will be a negative feedback mechanism, and then the hypothalamus stops the release of thyroid releasing hormone. This is how the normal physiology or the feedback mechanism that happens in the case of thyroid hormones. Suppose if the thyroid levels in the blood are very high, then the hypothalamus automatically stops the release of thyroid releasing hormone. Okay. Now, how are these thyroid hormones formed? In a very simple way, I'm not going to go into the detailed steps. So, we should know three things. One is the plasma. This is the follicular cells of the thyroid, and within the follicular cells, we have something known as thyroglobulin. So the iodine which is present in the plasma will move into the follicular cells, and inside the follicular cells, this iodide undergoes oxidation in the presence of the enzyme peroxidase to form iodine. Now this iodine from the follicular cell will go into the thyroglobulin, where it binds with thyroxine and undergoes a process known as iodination with the help of the enzyme iodinase. And this leads to the formation of two important molecules, the monoiodotyrosine and the diiodotyrosine. So when one of the monoiodotyrosine and diiodotyrosine combines, it forms T3, and two molecules of diiodotyrosine combines to form the T4, and once they are formed, they get released into the plasma and show their action. Okay. So now in thyroid storm, what is the pathophysiology? Okay. The first could be, it could be due to heightened tissue response to thyroid hormones. The thyroid hormones are released properly, but there is a problem within the tissue. Second, there is decreased affinity of the thyroid binding proteins for the thyroid hormones. So there is free thyroid hormones that are available in the plasma. Third, there is enhanced binding to thyroid receptors. Fourth, there is abrupt increase in free thyroid hormone availability due to some either exogenous production or due to the production from any other organ systems. And the last would be the loss of homeostatic interaction between the thyroid hormone and the sympathoadrenal system. So this is the pathophysiology behind the thyroid storm. 5 important processes which happens. Okay. Now coming to the clinical features. So here we have divided the clinical features into a systematic manner. So the systemic features could be fever, diaphoresis or weight loss. And the fever in this case could be very high. Okay, 104 to 106 Fahrenheit. Coming to the cardiovascular system symptoms or signs. There could be tachycardia. The most commonly seen is sinus tachycardia, atrial fibrillation and ventricular fibrillation. Okay, there could be systolic heart failure with pulmonary and peripheral edema. There is high uh, output heart failure or high cardiac output heart failure. There is wide pulse pressure with systolic hypertension. These are the cardiovascular changes which are seen in thyroid storm. Gastrointestinal, patient might present with nausea, vomiting, diarrhea, abdominal pain, and in certain cases there could be jaundice also. And in neurologic, we all know tremors, restlessness. The patient could be agitated, anxiety, delirium, okay, hallucinations, and if it is severe enough, even stupor and coma also. The other presentations which they can do is the patient might have a goiter, he might directly present with a goiter, okay, or a scar from partial thyroidectomy or exophthalmos. Okay, so these are the common clinical features that the patient presents with. Other than these, there are other rare manifestations of the thyroid storm which has been seen in some of the case reports. Okay, like severe abdominal pain with some peritonitis features. Patient might even present with status epilepticus, rhabdomyolysis, hypoglycemia, lactic acidosis, and even DIC. So these are the rare manifestations of the thyroid storm. So now how to diagnose? Actually, thyroid storm to diagnose would be a very challenging process because it has, as you see, all the systems have been involved and you have a lot of differential diagnosis for this. And the presentation is actually non-specific, right? Because major organ systems have been involved. So do a routine lab like CBC, electrolytes, renal functions, liver functions, coagulation profile, and important is the thyroid profile. Do an ECG and urine analysis also. So as we all know, in the thyroid profile, the TSH will be very low, the T3, T4 levels will be high. Okay. And these patients usually present with altered mental status. So you need to rule out the other causes for altered mental status. So do a CT, non-contrast CT to rule out other brain factors. Okay. Blood cultures and chest X-ray if you suspect any infection, because infection is one of the a precipitating factor for thyroid storm. Okay. And any toxic ingestion is suspected, then you should send acetaminophen and salicylate levels here. The important thing is we have two scoring systems that may assist in diagnosis of the thyroid storm. So when that score is there, then this patient might have a thyroid storm. Okay, so you have two scoring systems. One is the Birch-Wartowski scale and the second one is the Japan Thyroid Association criteria. The most common criteria we use is the first one, the Birch-Wartowski scale. So it includes around 6 important components. One is the temperature, one is the CNS effects, the gastrointestinal hepatic dysfunction, cardiovascular dysfunction, heart failure, and the presence of any precipitant factor. Okay. So you take this, see the symptoms, and then note it down. So if the total score is less than 25, then the thyroid storm is unlikely. Okay, 25 to 45 suggests that there is an impending thyroid storm. And if the score is more than 45, then it is suggestive that the patient is having a thyroid storm. Okay, so this is the Birch-Wartowski's point scale. Need not to remember the points and all, at least you should remember the components and the scale name. And the second is the Japanese Thyroid Association diagnostic criteria. So here they have divided the thyroid storm as definitive thyroid storm and suspected thyroid storm. So definitive thyroid storm is where you have a thyrotoxicosis features plus at least one CNS manifestation, plus there could be fever, tachycardia, or any of the organ involvement. That is the definitive thyroid storm. Whereas in suspected thyroid form, you have a combination of two of the following along with thyrotoxicosis: the fever, tachycardia, the congestive heart failure, or GI or hepatic manifestations. Okay, so this is about the definitive thyroid storm, suspected thyroid storm. Just know the name: Japanese Thyroid Association diagnostic criteria. I need not to remember the components. All this is just for the information that we have given. Now coming to the differential diagnosis. So because it involves multi-organ, so we have lots of differential diagnosis for thyroid storm. The important is sepsis, psychosis, cocaine use, pheochromocytoma, and these three are important for us: neuroleptic malignant syndrome, malignant hypothermia, and serotonin syndrome. We need to differentiate this from thyroid storm. Any anticholinergic or adrenergic drug intoxication, CNS infection, and hypertensive encephalopathy. So these are the differential diagnosis for thyroid storm. This is just a table which is giving some differentials between the important things which I've told mentioned in the previous. So if you see, this is the thyroid storm here, and I told malignant hypothermia, neuroleptic malignant syndrome, serotonin syndrome. So you should know about what are the differentiate features. So in all of these four, there is a lot of impairment in the mental status. So patient will be usually drowsy or very much agitated in these cases. Whereas if you see the pupils, it is dilated in case of serotonin syndrome, whereas in all the other three, it is normal. Important for us is coming to the muscle tone. Okay, it will be rigid in malignant hypothermia, neuroleptic malignant syndrome, and serotonin syndrome. This is one of the differentiating feature between the thyroid storm and the other three. Okay, even the mucosa and the skin would be wet in these three cases, whereas in the thyroid storm, it is normal. Okay, so these are the important, especially the muscle tone you should know for the differentiating features. Okay, now coming to the treatment. So treatment, the first important thing would be treat the underlying cause. The other two would be, one is the supportive measures, and third one would be the specific measures to treat the hyperthyroidism. So supportive measures, like you need to treat the fever, hydrate the patient properly. If oxygen is required, put the patient on some oxygen. Okay, so these are the supportive measures which you give. And we will discuss in the further slides about the specific measures. And as I told, treatment of the precipitating factor is very, very important. All these patients has to be admitted into the ICU with close cardiac monitoring and ventilatory support if needed. Now coming to the specific strategies. So this is the important thing that you should know. So there are 5 important specific steps or treatment methods that you should know. So the first one is the therapy to control the increased adrenergic tone. Okay, which usually happens in the thyroid storm, for which you give the beta blockers. Second, the therapy to reduce thyroid hormone synthesis, for which you give thionamides. The third, the therapy to reduce the release of the thyroid hormones by giving iodine solution. Fourth, the therapy to block the peripheral conversion of T4 to T3. So this can be done with the help of iodinated contrast agents, glucocorticoids. Propylthiouracil has the additional benefit of having to block the peripheral conversion, and even propranolol. And the last therapy would be therapy to reduce enterohepatic recycling of thyroid hormones, which can be done with the help of bile acid sequestrant. Okay, so these are the 5 specific steps for the treatment of thyroid storm. Okay, so we will go with each of it. So first I told beta blockers. So after the initial supportive measures which you do, you need to start up beta blockers for any case of a suspected thyroid storm. Okay, you calculate the score is coming more than 45. So start off with the beta blockers. The best beta blockers would be propranolol. So start with 40 mg to 80 mg and you have to give every 4 to 6 hours. Okay. So if the patient in the ICU setting, you can also try IV esmolol. Okay. And in patients who have a reactive airway disease, you can even use cardio selective beta blockers like atenolol or metoprolol. And if there is any contraindication for the use of beta blockers, you can use calcium channel blockers like diltiazem also. So this is the first thing you do after doing your supportive measures. Start a beta blocker. So after starting the beta blockers, you give your thionamides or your anti-thyroid medications. The most commonly used is the PTU, that is the propyl thiouracil or methimazole. So if you're giving thiouracil, the loading dose would be 500 mg to 1000 mg, which is followed by 250 mg every 4 hours. Okay, if it is methimazole, it is 20 mg every 4 to 6 hours. Okay. As I told, propothiauracil has an additional effect of blocking the peripheral conversion compared to your methimazole. So you can start any one of these. So advantages of giving propothiauracil is that in the first 24 hours, it decreases the T3 level by 45%. So the symptomatic improvement is better with propothiauracil, whereas methimazole drops the T3 levels only by 10 to 15%. So they tell that in the initial few days, at least around 5 to 6 days, you give PTU and then convert it to methimazole. Okay, so methimazole causes more rapid normalization of serum T3 levels after a few weeks of treatment, and it has less hepatotoxicity compared to propothiauracil. So if you give PTU for the longer time, hepatotoxicity is very common. So the initial regime is to give PTU for around 5 to 6 days or for a week, then change it into methimazole. Okay. Now you gave first your beta blocker, then you given your PTU or methimazole. After 1 hour of administering your anti-thyroid medications, you need to give your iodine solution. That is the SSKI, super saturated potassium iodide. You have to give 5 drops. Okay. And they always tell that we need to administer the thionamides before starting this iodine solution. Why? Because when you give this iodine solution, because of increased iodine load, if you see the thyroid hormone synthesis, iodine is very important. So if you give it before the thionamide administration, there will be increased thyroid hormone synthesis, actually worsening your thyroid storm. So first give your uh, thionamides, then after 1 hour, give your iodine solution. Okay. So 3 drugs have been done. Post that, you can give hydrocortisone or dexamethasone because this also helps in blocking the peripheral conversion of T3 to T4 to T3. Then comes your last, for severe cases, you can also use oral cholesterol, your bile acid sequestrant, 4 grams 4 times daily if there is an availability. Okay. And if the patient is on ecospirin for any other reasons, like if the patient had a previous history of stroke or a cardiac patient, so better to avoid it in the initial few days, okay, 2 to 3 days, because aspirin has a potential risk of increasing the free thyroid hormone levels by interfering with thyroid binding proteins. Okay, so it causes less affinity of the thyroid hormones to bind to the thyroid binding protein. So there will be increased free levels of these hormones. So just avoid ecospirin at least for 2 to 3 days in the acute phase of the thyroid storm. So this is the 5 steps or the 5 drugs which you give here. Next, suppose if you are not able to give thiamide therapy for any reason, okay, then give the other drugs and then plan for a thyroidectomy as early as possible. Okay. And once the patient's clinical condition improves, you have to stop the iodine solution. Glucocorticoids should be tapered and stopped, and beta blockers should be adjusted. So iodine solution should be stopped and steroids should be stopped, but continue with your beta blocker and your propylthiouracil or the methimazole which is there. And the definitive therapy in these patients would be the radioactive iodine therapy or the thyroidectomy. Suppose if the patient is having Graves' disease, then you should plan the thyroidectomy surgery for these patients after stabilizing these patients. Okay, it usually requires 5 to 7 days for these patients to get stabilized, then post them for thyroidectomy. But the patient is very, very sick. You have tried all these medications, not happening, then plasmapheresis is the last resort if any other measures fail. Okay. Now coming to the prognosis. As we all know that thyroid storm is a medical emergency. So we need to treat it as soon as possible, and most of the patients actually improve within the first 24 hours. Risk factors for poor prognosis include those patients who have an advanced age, if there are some neurological deficits on admission, failure to use beta blockers and antithyroid medications as soon as possible, and if there is a need for dialysis or patient is on mechanical ventilation. Basically, the patient is having multi-drug organ failure and the patient is worsening very fast. Okay, and the complications, as we all know, as I told, the causes of death, right? All of the organs have been involved. So there could be arrhythmias, high output cardiac failure. In the brain, there could be seizures, delirium, coma, elevated liver enzymes, or as I told, important thing in GI is there it could be GI perforation. And in the heart, the most common manifestation of the arrhythmias is AF. And there could be in some cases thromboembolic phenomena. Okay, so these are the complications of the thyroid storm. Okay, so this completes your thyroid storm, especially the medications. Basically, you should know those 5 important specific management strategies are very important. At least you should know the uh, mechanism of action and what drugs do you give and the doses. And how do you give it is very important. Which to give first, then which to repeat. Okay, that is very important. Any questions? Okay, so if not, we will leave the session for today. Okay, thank you.